everyone, and welcome back to MedSynapse podcast series. I'm your host, Hetvi Shah, and today we revisit a topic that is gaining increasing attention in women's health, which is uterine fibroid embolization, or UFE, a minimally invasive fertility-preserving alternative to surgical treatments like a myomectomy and hysterectomy. And joining us once again is Dr. Avinash Malla, an interventional radiologist and returning guest on our platform. His expertise in image-guided therapies and commitment to patient-centered care have made his insight widely appreciated in the MedSynapse community. So, Dr. Avinash, welcome back, and it is so great to have you with us once again.
Thank you. Thank you, Hetvi. It's great to be on this platform again, since a lot of people are getting aware. Awareness is what's very important that we have discussed last time. So,
Absolutely.
I'm very happy to be here.
Same here, doctor. So, Dr. Let's just get started with uterine fibroid embolization. So, in your clinical experience, what are the key criteria for selecting patients for UFE instead of opting for surgical options like myomectomy or hysterectomy?
Yes, right. So, thing is, like, for many people, it is very common the fibroids are there in the uterus, right? So, for most of them, the symptoms doesn't occur. The symptoms occur, there is something called heavy bleeding, or, while periods, there will be a lot of pain. Those can be contributed by fibroid, right? And people, when they suffer from something like this, they go to the doctor, they get scan done, and turns out that they have fibroids. As long as there is no second pathology, right? So in any case scenario, for example, a pain can be attributed to many things. The same way, these symptoms can be attributed to one or two things, like fibroids, or there might be some gynecological, uterine cancer or endometrial cancer. So we need to make sure that the person who is suffering from, or the patient who has been diagnosed with uterine fibroids, and the symptoms are correlating with fibroids, right? If anything is odd, or if there is anything wrong in the imaging, and you would be knowing that every woman who is above 40, 45 has to go through pap smear. Like, that is something to detect cancers of endometrium. So we confirm that as well. So if there is something, a component which will point towards a cancer, we advise the patient to go for hysterectomy, right? But if there is nothing like that, and there are only fibroids, so that patient is fit for uterine fibroid embolization. So there are benefits and risks here, right? So in surgery, if a person is going for a hysterectomy, right? So the hysterectomy is like removing one of the pillars in the pelvis. So the overall integrity of the pelvis changes. So in that case, our uterine fibroid embolization, that doesn't disturb the anatomy of anything in the body. We just target the fibroids. So for them, uterine fibroid embolization is much more useful than hysterectomy. And coming to myomectomy, right? Myomectomy is again a procedure to remove the whole fibroid as in toto with laparoscopy. Yes, we do advise them for patients who has very big fibroids. And they were like, if we predict that after uterine fibroid embolization, the remnant fibroid, which is dead, which is not active, but then again something will be remaining. So if it is a very huge fibroid, so what we do is we coordinate with obstetricians. We do uterine fibroid embolization, and then we send, the patient is referred to them. They go, once it's a 10 centimeter or 11 centimeter fibroid, comes down to 4 or 5 centimeter or maybe 3 centimeter. As long as it is not affecting the patient, it's okay. If the patient is like, no, I want to remove it. For example, patient who is planning for conception for kids. For them, even the smallest one sometimes is a disturbance in the room, right?
Yes.
For a person who has completed the family, it doesn't matter. For a person who wants to, explore the conception, explore getting kids, planning for kids. So for them, we work together with the obstetrician as well. Removing that fibroid gives them a chance, to...
Yes. So I think it is like individualized assessment is actually really helpful for success of UFE. So now, doctor, for our interventional audience, can you walk us through the technical workflow of UFE from access site choice to embolic agent selection? What does a typical procedure looks like?
Typically, procedure in our or like so far what people have done is to going through the groin. It's called common femoral artery. So the artery that goes to the legs, right? We go into that artery and we climb our way upwards and then find our way to the uterine artery. Uterine artery is the artery that supplies blood to the uterus, right? Once we go inside, we use contrast to see where is our position exactly. So the material which we use, the whole, embolization means blocking that particular artery. So we block, before blocking anything, we need to be sure that we are in the right place. So we confirm that the blood supply on the arteries which we are inside is actually going to the fibroid. Once we know it's fibroid, then we plan for we use materials like it's medical grade plastic, okay, or sand particles if you want to, compare. So these particles, they're called PVA particles or embospheres. We use either of them to block the arteries of that particular fibroid at the capillary level. It's like, imagine a tree. So from the branch, you're going higher up to sub branches to the point where it reaches the leaf. So we are targeting the leaf. The leaf is the fibroid here. So once whatever we release the particle or whatever we release the medical grade embosphere, those particles will sit at the level of the leaf, which is a fibroid, and blocks on the way. So in that way, the fibroid will, we deprive it of oxygen and it dies and shrinks off. Right. So this is our usual process. We use, nowadays people are using radial punctures. Radial is in the hand. That's called radial artery. For people who know about cardiac, who has the experience of cardiac angio, or who is most of the families nowadays has one person who has got cardiac angio done, right? So for them they use radial. Okay, from the hand they go and to the heart. So nowadays the technology has come to the point where we can use radial as well to go down. So for this, since it's no general anesthesia and patient will be awake all the time, so patient can walk out of the hospital by the end of the day or maybe the next day, immediate day to go home. Like those risks are not there. The general anesthesia risks are not there.
Yeah, I think that is where interventional radiology comes into picture, and I think that was such a clear and structured breakdown, doctor. Now, of course, no procedure comes without risk. So what are some of the most common complications or challenges that you have faced in UFE, and how do you, typically mitigate them?
So pain is the most common and the first part, right? Absolutely. So whenever we are cutting off blood supply to a certain organ or a certain thing, it dies, right? So when it dies, it has a habit, it excruciating pain will be out of it. So for that, what we do is we keep, for the first 24 hours, we keep on IV medications. Not our tablets won't work, because the first 24 hours is important. Once the immediate changes will happen in first 24 to 48 hours. After that, the body gets accustomed to it. Okay. So for that, we use IV drugs to control the pain. And then we also use something called superior hypogastric nerve block. So last session, if you remember, we discussed about nerves, right? So this time, the superior hypogastric nerve block also cuts off the pain that is taken from the pelvis, like pelvic organs. So first, out of which, first 24 hours, first 8 hours will be taken care by this block. So the patient has some pain, but not, unbearable or impossible kind of pain. Apart from that, there is a minor chance, out of 100 people, maybe 1 or 2 people will be having puncture site hematoma, where we go inside the artery. So at that place, some bleeding will happen and some hematomas will be there. And these are the common risks which are taken care of. 1 in 100 or so, what happens is that the particle which we use, the embolic material, that will go to the place which we don't intend to. right? Our target is fibroid. So there are so many other things in the body that should be. So sometimes what happens is that this embolic material, the particle, will go into some other place and starts killing that part. So that is a one complication which can happen. So we have to be pretty sure that we are in the right place. So technology allows us to do that.
Correct.
So there are on-table CTs that happen. So with this kind of technology, it helps us to make sure that we are in the right place and hitting the right part. And yeah, that's where the skill comes into picture.
True. That is where actually, experience hands also make a really great difference also. So Doctor, this brings us to an important concern, like how do you counsel women of reproductive age who are considering UFE versus fertility-sparing surgical options? I think this is in relation to the first question that you were talking about.
So as we have discussed, like for people who have finished their family, for them, uterine fibroid embolization is something that we highly recommend, right? But then for people like who is planning for conception or for kids, I would say from my side, I would explain everything that is there for uterine fibroid embolization. And then I would want them to go to a obstetric gynecologist and then listen to what they are saying. So at the end of the day, it's their decision to take and decide on what helps better. So I spend a few more minutes, maybe 10-15 minutes more than a regular patient, try to understand what they want. So for people, as I told you, like huge fibroids, which requires, risky and tricky, reduce the size so that when the obstetric gynecologist goes in with the laparoscopy, it makes a huge difference when you're trying to remove a 10 centimeter fibroid than a 4 centimeter fibroid.
Right.
So, and that way they can reduce the damage to the uterus and other organs inside the abdomen, right? Preservation is the key. But then, so myomectomy helps in removal of the fibroid in complete sense, right? And then uterine fibroid embolization, the fibroid doesn't vanish. It just becomes inactive.
Right.
And the size reduction will happen. Almost 60-70% size reduction will happen. But maybe 1 or 2 centimeter fibroid is still there. So if it is in a place where it can affect pregnancy or something. So I would want them, even before going for this option, even before we do something for the patient, I would want the patient to sit and listen to both the versions and then take an informed decision on what they want. So we have done both ways, like this way, and there were patients who would want for a complete, because it's only 2 centimeters, 3 centimeter fibroid. So why not? Let's go for a myomectomy. So we have sent the patient like that as well.
I think that's such a balanced approach, doctor, because respecting patients' autonomy is really important, actually, without laying their real expectations also. So now, doctor, to wrap up, what research gaps do you think still needs to be addressed to strengthen UFE's role as a mainstream treatment option for fibroids?
Research-wise, I don't think so. There is not much, because it's been proven that uterine fibroid embolization is working, and many people who have come with the complaints have gone with resolving of their symptoms and everything. So I feel again the awareness of people knowing, because there are so many who has got hysterectomy done. And when you ask them what is the story, they say it's because of fibroids that hysterectomy is getting done. But they didn't realize that there are other problems that follow after hysterectomy. So if it is a cancer, or if it is something which is very dangerous, go for a hysterectomy. Because it has to come out of the body, it has to be taken out of the body. But if it is benign, if it is not something that's gonna aggressively grow or hurt you, go for a non-invasive methods. People don't know it. I always while explaining to the patient, I do say one thing, that if you think that this treatment doesn't work, you can always go for hysterectomy, because it is still there.
Absolutely.
Right. So, but if you think that this works, give it a chance, see if it works. People don't know. People don't have an idea that something like this is exists.
Gonna happen,
Yeah. So I think it has to reach the people. it has to reach patients. But otherwise, research wise, there might be something which I don't know. So that's how advancements are always there. So there was no uterine artery embolization at one point. So this has come. Something else might come. We don't.
Yeah, definitely. And I think
I don't have an idea.
valid point that you brought upon. And obviously, advancement is something that will just keep on happening each day. So you can't always keep up with it. So, Doctor, thank you so much once again for joining us and sharing such practical and forward-looking insights on UFE. So, your contributions actually continue to add value to clinicians and our audience. So, thank you so much for joining us once again.
Thank you. Thank you very much for the opportunity. And I hope, more people understand this and then find the right treatment option for that. Be
That is really important.
Or be it uterine fibroid embolization.
Yeah, correct.
You have to be counseled by the right person so that you can take a good decision, informed decision.
True. That really matters a lot. Experience does matters in this case, I would say. And to our audience, remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay informed and stay connected.